So, hello everyone. My talk is about DMAT, enhance mucosal immunity and enable dose sparing in oral cholera vaccination. Cholera is an acute diarrhea disease caused by Vibrio cholerae, mainly transmitted by contaminated food and water. Bacteria produce CT, which will lead to water and electrolytes loss in small intestine and cause severe diarrhea and dehydration. It could cause death within hours if untreated. CT contains two subunits. CTA is a bad guy which causes toxicity, and CTB is a delivery guy bound to GM1 receptor and enable the entry of CTA. So because cholera won't enter into tissue or blood, but CT do. So secret IgA, which bind to CT, is crucial for cholera protection because it provides first line of defense at the infection site and the neutralization of cholera toxin and prevention of colonization. It will reduction of pathogen shedding. So just remember, secret IgA is most important. That's what I will test. We're currently experiencing global burden of cholera. It's about 1.3 to 4 million cases per year and up to 143,000 deaths annually. And endemic in 47 countries, mostly in Africa and Asia. Of course, WHO tried to end cholera, and the aim for 2013 is to reduce cholera deaths by 9%. But except a better monitoring system and hygiene, what we can do in lab is promote oral cholera vaccination. So let's talk about oral cholera vaccines. So oral vaccines is good. First, it's a needle-free, so who likes needle? The oral vaccine will give more peace, of course, and induce mucosal immunity, lead idea for mass immunization, so it's easy to perform, and safe for low resource setting, and cold chain flexible. So because this vaccine will be used in a low income country mostly, so it's much cheaper, so it's really important. But the challenge is also real. First, the antigen degeneration in GI tract is always a big challenge, and oral vaccine generally has lower efficacy than the injectable vaccines. So we need really strong oral adjuvants, which can boost the immune response. We have 3 commercial cholera vaccines at the moment. So first is Ducrol, which contains both bacteria and the protein, which is the recombinant CTB, and the Shankol and the Evicol. The other 2 only contains bacteria. So we can see Ducrol has slightly better protection rate than the other 2. Because we're currently experiencing cholera vaccine shortage, there's way more demand than supply. So WHO can, because with a limited stock, so WHO can't do anything, just introduce the temporary dose reduction policy, which means the shift from 2 dose, that's a full dose, to single dose, so half dose. So will this really work? So researchers already found out it's better than nothing, but it also plays a crucial role in an emergency situation, but it's not good enough. First, the duration of immunity is much lower, much shorter, and the efficacy in adults much lower, and it's not really effective for kids under 5 years old. But there are about 15% cholera deaths are among kids under 5. So we do need a better solution, and that could be oral adjuvants. But the question is, so there's no oral adjuvant at the moment. So if our oral adjuvant is so important and so good, why is no? So adjuvant is something in adult vaccine to enhance immune response to antigens. And the oral adjuvant we want can boost mucosal immunity, of course, and increase oral vaccine efficacy, enable dose sparing. So why is no adjuvants? Some people may ask, wait, because actually when I ask ChatGPT, they say, yeah, there is oral adjuvant, which is a CTB, because CTB has been recognized as adjuvant for many years. But the question is CTB really an adjuvant? Actually, researchers found out many years ago, recombinant CTB is not an effective oral adjuvant. And my supervisor and the colleague highlighted in Nature reviews that CTB is only mucosal subunit antigen, not an adjuvant. So let's look at dmLT. dmLT is the most promising mucosal adjuvant. It's a double-mutant E. coli heat-labile toxin, and it's safer and stimulates stronger mucosal immunity. And it's already used in phase 1 and 2 studies in ETEC, Shigella, and poliovirus. It has been proved to be safe in adults and children and can enhance antigen-specific immune response at the mucosal sites. So it's really important, and enable low-dose orally delivered vaccines. So the question is, can dmLT work boost DUCRO? So in order to answer this question, we include both male and female. So it's really a big challenge because my supervisor says it's really dangerous because always female work well, but male not really. But he doesn't believe that because he's a male, and he said if the adjuvants only work in female and not male, so male will all die, but not really. So yeah, so I have two, like a PBS group, DUCRO, and DUCRO plus dmLT group for both sex. And the mice are immunized 3 times and sacrificed, of course. And then for B cell responses, analyze, we collect fecal serum and the small intestine for IgG, IgA, IgG2C analysis. For T cell response, we collect the spleen and the local lymph nodes, the mesteric lymph nodes, and the cell were cultured and restimulated with DUCRO for 72 hours. And alpha gamma and IL-17 were analyzed. Just remember, the secret IgA is most important for cholera protection, and in the fecal IgA, it's like a fecal IgA represent a secret IgA because the tissue IgA not all the tissue IgA can secrete to the lumen. So that's our most important data. So fecal anti-CDB IgA, and we are really lucky because we get a significant increase after addition of dmLT in. Oh, sorry. In both male and female. So, yeah. And for female, they're about 39-fold increase, and for male, they're about 195-fold increase. So that's really, really we are really happy about that. And for upper for tissue IgA, the upper intestine and the lower intestine IgA. So similar pattern. So both female and male, female. Shows significant increase after addition of dmLT. So let's look at the serum antibody. So for serum IgA, not so much difference in female, but for male, surprisingly, we see significantly increase after addition of dmLT. For IgG, we see significant increase in both sex after addition of dmLT, but the male seems better. Much better. And for IgG2C, only a significant increase observed in male after addition of dmLT. So for cytokines, the dmLT induced IL-17 and alpha gamma. No much increase or significant increase can be seen in spleen for either alpha gamma or IL-17, but we see a significant increase in local lymph nodes. For both alpha gamma and IL-17. So the final question is, are the antigen-specific secret IgA functional? If it's functional, it can neutralize the CT. So in order to answer this question, we develop a competitive ELISA. For non-competitive ELISA, we immobilize plates with GM1 and followed by CTB, and then the fecal sample, which contains anti-CTB IgA. So then the specific IgA will be detected. So the signal is higher, better, so we know that. But so that means there are more specific anti-CTB IgA. But for competitive ELISA, we instead of add a fecal pellet onto the plates directly, we incubate a fecal pellet with a free CT. So if the IgA in the fecal pellet is functional, it can bind to CT, and CT actually block the antibody, and antibody won't bind to the CTB, and then it will be washed away and cannot be detected. So in this case, the signal is lower, the better. That means more antibody can bind to CT. So what we see is exactly what we expected. So there are much more signal before competition of CT, and after competition of CT, the significant decrease we can see. So it's really good. So that means the fecal secret IgA is functional. So the conclusion, Ducrol and DMAT increase systemic and mucosal immunity in both male and female. And the fecal anti-CTB IgA is functional. And it may enable the dose sparing. So thank you. Thanks my colleagues and collaborators and my PI, of course. Thank you. So any questions?
Thank you very much. Can you tell us a little bit more about the adjuvant itself? Has this been used at all in any other studies as well, or
in our lab?
Well, in other labs as well.
A lot. That's sorry. This one is really mature, because that's why it has been used in phase 1 and 2 clinical trials in many studies. Mm-hmm. So this one, if you Google, there's thousands of papers about this one.
So from a point of view of the next steps for you, I guess it's really looking in the clinical setting and seeing what the effects are?
Actually, not really, because our lab, we screened many adjuvants. This one is actually our positive control, because we still have problem to share this publicly, because we have a different oral adjuvant, but this one is always used positive control, and it's lucky enough, it's positive enough, because some adjuvants not really work in male, and also it's up and down. So sometimes I change mice, and the mice won't respond at all, because the antibody cannot secrete from the tissue. The tissue has really high IgA, but the fecal have almost 0. So this case happened for many adjuvants, so it's really challenging. But this one, so far, stable enough. But also we have actually different adjuvants. So we won't continue with this one, to be honest, but we will continue with other.
Okay, but I'm just trying to understand, so if it's this good, why isn't it already being used clinically?
Sorry?
If it's this good, why isn't it already being used for cholera?
So it's already in the clinical trial, but just I think it takes a long time.
Sure, yeah.
Yes.
Okay. Thank you.
Thank you.
Following this question, can you speculate on the mechanism?
Sorry?
How is working this adjuvant? Because you showed us some data, for example, of T cells that were producing more IL-17, but these were what, antigen-specific in the spleen? I mean, can you speculate about?
Sorry, I have slides.
Okay,
but
good.
my don't want me to.
Prepared.
Yeah. So do you mind to help me to show the slides again? And how is that in the backup? Sorry. Kind of. But basically, sorry. Go through all of them. Sorry. Yeah. So after the DMAT mixed with antigen, and they were oral, of course, after oral gavage, the DMT were bound to CM1, and then promote triggered in the endocytosis, and mild CAMP rise, and then promote the maturation of dendritic cell and macrophage, and then promote the Th1 and Th17 polarization, and then start the B cell B cell classification, and that's produce IgA, and then also after some secrete process, the secrete IgA will be secreted, and then stimulate the mucosal immunity. So basically, that's the general how it works.
So this will happen on the oral part of the gastrointestinal system.
It's not sublingual. It's oral gavage. Sorry. Yeah.
So you are basically.
Go to the stomach.
So you are bypassing the stomach.
Yeah, I insert the needle to the stomach. Yeah.
Okay. But then if you use it in humans, it has to go dry?
No, it's just swollen. It's just swollen. So it's fine. Okay. You should. You won't.